Now, I reference you all the time. You're probably my most cited academic because you have had such an impact on me, the work that you do in stigma reduction, in mental health awareness. Tell me a little bit about that work that you're doing at Queen's in your Bell Canada chair.
Well, there's two prongs to it. The first prong is to try to give people voice. So we know that people who have mental health and substance use issues, as part of the whole process of marginalizing them, they don't have voice in what happens to them. So it hasn't been, until very recently that we've started to ask them about their stigma experiences. Up until, well, even as far back as the 50s, it was the researchers that would sit in a room and decide what stigma was and how it worked and how it played out. So part of my job, I think, is to give people voice. So I like to do surveys that ask people what their experiences are, the frequency and magnitude, or qualitative studies. But that's not enough. And not enough just to say to policymakers, oh, we've got this big problem here. You have to also come up with some solutions as well. So you can say, here's a problem, but here's some solutions that you might consider. So the second part of my work is trying to figure out what works to reduce stigma and do the research and science around the implementation of these programs to be able to demonstrate that they're effective.
Now, you've spoken before about how the best way to or how we reduce stigma, the best ways, the best scientific ways to reduce stigma, and maybe broad-based mental health awareness campaigns like Bell Let's Talk Day or Time to Change in the UK that might play a role, but it's probably not the whole picture, right? We should be doing some more targeted interventions too, correct?
Right. I mean, when you think about what stigma is, it could be at the level of the individual person and the way they self-stigmatize, internalize shame and blame. It could be at the level of how people interact with each other at the public level and what, we generally as a community think about people who have a mental illness and how much we're willing to interact with them. But it's also structural. So it's the laws and policies and practices that organizations have that somehow inadvertently or directly marginalize people. So depending on what kind of stigma you're talking about, you must tailor your intervention to that specific type. So what we would want to do in the case of helping people become empowered, and overcome self-stigma is not at all what we would do if we were trying to change a policy or a law. So we have to target programs, as you said, to make them reasonable for what our goals are for that particular type of stigma. And what that basically means is one size doesn't fit all. Each type of program can play a component role, but to really change our entire culture, we've got to be working at all these different levels simultaneously.
Now, not all stigma reduction programs are created equal, however, and there's been some research to suggest that there are some programs, while well-intentioned, might actually have the opposite impact, might embed stigma further or make issues worse. So how then do we disentangle those? How do we develop truly evidence-informed stigma reduction programs?
Well, that's the trick. I mean, so many people in the advocacy world go out and create a program and implement it because they believe it works. Mm-hmm. They have the best of intentions. They don't necessarily have the relationships with university researchers or the funding or even the time to really work on evaluating what they're doing, whether it works. So we need to build those relationships. But over time, we've learned that some things really just don't work. And anything that promotes labeling doesn't work. So anything that promotes this notion that people don't recover, so really focusing on a biological underlay to mental illnesses in the public's eye, that usually means there's some sort of a brain dysfunction. It's never going to get better, and those people are never going to recover. So illness, like any other kinds of messages, have not been as impactful as we would have hoped. In fact, they've sometimes increased stigma, public stigma.
In your view, as a stigma researcher, as somebody who's, and one of the leading experts in this field, does the fact that we're failing so abysmally to help so many people recover from their mental illness mean that therefore it's impossible, that recovery from mental illness is impossible, that there is such thing as incurable mental illness?
Yeah, well, that's what, that kind of approach to treatment and management, that's the message. But when you think about it, this is the structural piece. Policymakers have really not put mental illnesses at the top of their policy agenda. And if you think about it globally, you can see that some countries are abysmally underfunded. They still have people put them in cage beds and lock them away in hospitals because they don't, or chain them to trees because they don't have alternatives. So, the has not been the top of the, people's mind to fund. And if you suck money out of systems or don't fund them properly in the first place, yes, of course, you're going to give people the impression that these illnesses are incurable. But we know they're not. And we know that we have a new definition of recovery in the mental health field that talks about people overcoming their symptoms, not necessarily taking medication or learning to live with them, and living full and meaningful lives. And that's our definition now of recovery, not that you completely eliminate any clinical symptom or sign, but people learn to manage them, and they may have setbacks from time to time. But that's part and parcel of the journey that they take.
Sure, and I mean, in my personal experience, it's not even always a matter of just being cursed to perpetually manage a chronic condition. It's that you come out the other side of it different than you went in. And I think if you're framing recovery as wanting to get back to the way you were, we've been talking about a lot about going back to normal in the context of a pandemic, and I don't think there ever is really going back. You can't go home again, as they say, and I think that applies to mental health recovery too.
I think it also applies to many physical health conditions as well. Like, I don't think you can go through a very significant physical health event and come out the other end as the same person. You can't do the same things that you used to be able to do. It's, there's a similarity there, and you have to figure out either you can rehab yourself back to exactly the same place you were, but many times you can't. And so what can you do to make your life meaningful and hopeful? And I think the same thing applies to people with mental health problems as well.
Yeah. Dr. Heather Stuart is the Bell Canada Chair in Mental Health and Anti-Stigma Research, a perfectly fitting guest, of course, for Bell Let's Talk Day. Thank you so much for joining me today.
You're quite welcome, Mark.